Imagine intentionally stopping a human heart. I mean, draining the blood from the central vessels, keeping the brain alive with a machine, and then while all that's happening, you surgically rebuild the engine.
It sounds totally fabricated, right? Like
Mm.
pure science fiction.
Yeah, exactly. But in a cardiac operating theater, it's honestly just Tuesday.
Right. It's completely routine for them. But, usually when people think about surgery, there's this expectation of mechanical simplicity.
Like a mechanic fixing a car.
Yeah.
You find the broken part, you swap it out, stitch it up, and you're done.
Yeah, but that plumbing analogy really only takes you so far. When you step into the world of cardiac surgery, that simple mechanical metaphor it completely falls apart.
Because it's not just pipes.
Exactly. You're dealing with a living, electrically charged, chemically driven organ that you somehow have to freeze in time, dissect, repair, and then, convince to start beating again.
Which is wild.
It is. You can't just be a good mechanic. You have to be an absolute master of the physiological environment.
And that is exactly what we are exploring today. We're doing a comprehensive educational deep dive into the foundational text, Key Questions in Cardiac Surgery.
Right. By Noreen Moorjani, Nicola Viola, and Sunil K. Ori.
Yeah. And our sources for this deep dive are steeped in evidence-based, clinically focused guidance. We're talking stuff built straight from the American Heart Association and the European Society of Cardiology guidelines.
And the mission for this deep dive is really to bridge that gap between textbook theory and bedside reality.
Definitely.
Whether you are a medical student prepping for rounds, maybe a surgical trainee, or a young healthcare professional, we are going to provide you with a thorough, high-yield summary of the entire perioperative cardiac surgery journey.
We'll cover the physiological foundations, cardiopulmonary bypass, major surgical interventions, and, of course, critical postoperative management, all avoiding unnecessary fluff.
Right. Keeping it clear and scientific. Because in this field, knowledge is most valuable when it's actually understood and applied at the bedside.
Okay, let's unpack this because before a surgeon ever even picks up a scalpel, they have to map out the physiological environment.
Absolutely.
And the text hits hard on the Bohr effect right out of the gate. Which, I mean, this isn't just some basic science concept you memorize and forget.
No, not at all. It literally dictates how we manage these patients minute by minute. The Bohr effect is really the foundation of tissue survival.
Right.
It dictates how the oxygen dissociation curve shifts in response to the patient's immediate chemical environment.
So if a patient is experiencing acidosis, hypercapnia, or even just an increase in core temperature,
that dissociation curve shifts to the right.
which means the hemoglobin undergoes this conformational change, right?
Yeah.
And it lowers its affinity for oxygen.
Exactly, making it much more willing to offload that oxygen directly into the tissues.
It's just a brilliant physiological adaptation when you think about it.
It really is. I mean, when tissues are metabolically stressed or they're working super hard, they produce acid, carbon dioxide, heat, and that rightward shift ensures that those demanding stressed tissues get the oxygen dumped right at their doorstep rather than it just staying trapped in the red blood cells passing by.
Wow. But balancing those blood gases is just one massive challenge. Managing fluid shifts post-operatively is another beast entirely.
Oh, absolutely.
And the sources rely heavily on Starling's forces to explain this. We're balancing capillary hydrostatic pressure, plasma colloid oncotic pressure, and the interstitial pressures.
Right.
So is it accurate to think of this like a household plumbing system, where hydrostatic pressure is the actual water pressure pushing out through microscopic leaks in the pipes, while oncotic pressure is like a sponge inside the pipe?
Driven by the plasma protein.
Right, driven by proteins trying to hold the water back.
That household plumbing analogy captures the exact bedside dynamic. I mean, if you are the junior doctor on the ward at 3 in the morning managing a post-op patient, you really have to visualize that sponge.
Right, because of all the fluids.
Exactly. Imagine a patient who has received massive amounts of IV fluids during a complex bypass. You have drastically increased the hydrostatic pressure, the water pressure pushing fluid out of the capillaries.
And if they've lost proteins.
Right. If their circulating protein levels are depleted from the sheer stress of surgery or blood loss, your oncotic sponge is completely compromised.
So the fluid just leaks out.
It inevitably third spaces into the interstitial tissues.
Mm-hmm.
And if that severe postoperative edema hits the lungs or the gut, your patient's recovery just grinds to a halt.
So you have to constantly manage both the pressure and the protein to keep the fluid inside the vessels where it belongs.
Exactly.
Once we understand that environment, we have to actually map the structural territory before operating. And the sources contrast two major imaging techniques here.
Transesophageal echocardiography, or TOE, and cardiac MRI.
Right, and TOE seems like the absolute gold standard for real-time visualization.
Oh, it is indispensable intraoperatively. Because the probe sits in the esophagus directly behind the heart, you get this pristine, real-time visualization without the ribs or lungs obscuring the view.
Which is huge during surgery.
Oh, massive. You can instantly assess a valve repair or, ensure there's absolutely no air trapped in the left ventricle before coming off bypass.
But there are strict contraindications for TOE, right?
Yes, there are.
Like, you obviously can't use it if the patient has esophageal varices. That makes total anatomical sense. But the text also lists severe cervical arthritis as a major contraindication.
It does.
Why does a neck joint issue prevent us from looking at the heart?
Well, think about the mechanics of it. Pushing a thick ultrasound probe down the esophagus requires manipulating the patient's neck.
Oh, right.
And in a fully anesthetized, paralyzed patient with severe cervical arthritis or instability, forcefully extending that neck could cause catastrophic spinal cord injury.
That makes sense.
You also risk esophageal perforation. So in those patients, you have to completely pivot your imaging strategy.
Which brings us to cardiac MRI.
Yes.
The text notes it's fantastic for evaluating thoracic aortic disease without radiation. But its role in ischemic heart disease is what really caught my attention. MRI is used to identify hibernating myocardium.
What's fascinating here is that cardiac muscle can essentially power down to survive a state of chronic low blood flow.
Like it's literally hibernating.
Exactly. The tissue isn't necrotic or dead, it's just resting to conserve energy. Now, on a standard echo, it's not contracting, which looks exactly like irreversible heart failure.
So you might think it's a lost cause.
Right. But a cardiac MRI can differentiate between dead scar tissue and viable hibernating tissue.
Wow.
And if the MRI proves the tissue is just hibernating, the surgeon knows that risking a massive bypass operation is actually worth it. Because once blood flow is restored, that muscle will wake up and regain contractility.
That is incredible. So we have the map, and we know what tissue is salvageable. Now we have to actually take the engine offline.
Cardiopulmonary bypass.
Yeah, CPB, which is a profound intervention. The text outlines 4 main aims we have to achieve simultaneously.
Adequate gas exchange to replace the lungs, systemic organ perfusion to keep the brain and kidneys alive.
Strict temperature control.
Right, and the salvage and retransfusion of blood.
And blood conservation has really evolved into a highly aggressive, active strategy, hasn't it?
Oh, absolutely. It's particularly illustrated by the protocol for Jehovah's Witness patients who decline allogeneic blood transfusions.
Right, you can't just react to bleeding with them.
No, you have to preempt it. Preoperatively, you optimize their baseline hemoglobin using erythropoietin. Intraoperatively, surgeons utilize continuous salvage circuits to instantly clean and return lost blood.
And they use MECC, right? Minimal extracorporeal circulation.
Exactly.
MECC uses a severely reduced priming volume in the bypass tubing, if I'm understanding that correctly. So you aren't diluting the patient's own circulating blood volume with liters of saline just to fill a machine.
Precisely. Hemodilution is the enemy of oxygen delivery.
Got it.
Post-operatively, the protocol mandates autotransfusion of shed mediastinal fluid and dictates a very, very low threshold to reopen the chest.
Meaning, if there's abnormal bleeding, you don't just wait and watch the drain.
No, you go back into the operating theater immediately to preserve their native volume.
But while the body is being perfused by the machine, the heart itself has to be stopped so the surgeon can work.
Right, which requires cross-clamping the aorta.
Which completely cuts off the heart's own oxygen supply. So we have to implement myocardial protection.
Yes. The classic method is cardioplegic arrest.
Flushing the coronaries with a cold, potassium-rich solution, right?
Exactly, to force electrical asystole and plummet the metabolic demand. But the sources also discuss off-pump techniques.
Where the heart keeps beating. They utilize intracoronary shunts and something called ischemic preconditioning, which I have a question about.
Sure.
If we are literally starving the heart of oxygen during a localized off-pump graft, how does ischemic preconditioning actually help instead of just causing early irreversible damage?
It's a great question because it seems entirely counterintuitive to intentionally cause ischemia to prevent ischemic damage.
Right.
But the biological mechanism relies on manipulating the cellular stress response. By exposing the myocardium to short, controlled, repetitive bursts of ischemia before the main surgical procedure, you trigger a cascade of intracellular pathways.
Do the cells adapt?
Exactly. They alter their energy metabolism and open protective mitochondrial ion channels. So when the prolonged actual ischemic event happens during the grafting, the cells have already built a temporary tolerance.
Wow.
It's all about fortifying the tissue against metabolic demand.
It's essentially giving the heart a cellular vaccine against oxygen deprivation.
That's a great way to put it.
So the heart is protected and the body is bypassed.
Yeah.
What exactly are we fixing? The sources focus heavily on three major pathologies: valves, the aorta, and the coronaries.
Let's look at the aortic valve first.
Yeah, your aortic stenosis. It has a notoriously deceptive natural history.
It really does. Patients experience a prolonged, latent, asymptomatic period. The valve slowly calcifies and the orifice narrows over years.
But the left ventricle compensates. Right.
By hypertrophying, thickening its walls to push harder against the resistance, so the patient feels completely fine.
Until they don't.
Exactly. Once that compensatory mechanism fails and symptoms appear, specifically dyspnea, angina, or syncope, there is a devastatingly steep decline in survival.
And the AHA class indications for surgery dictate that you must operate for severe aortic stenosis if the patient has those symptoms.
Yes. Or if their ejection fraction drops below 50%, even if they're somehow still asymptomatic.
Because an ejection fraction dropping below 50% means the left ventricle is actively failing under the pressure load, right?
Precisely. If you wait any longer, replacing the valve won't save them because the pump itself is permanently broken.
But sometimes the pathology extends beyond just the valve, like if the entire aortic root is dilated.
In that case, the text contrasts two major reconstructive surgeries: the Bentall procedure and the Ross procedure.
The Bentall makes logical sense to me. You cut out the diseased root and use a synthetic Dacron tube graft with mechanical or tissue valve sewn inside it.
Right.
But here's where it gets really interesting. The Ross procedure. Wait, we're fixing a broken aortic valve by stealing the patient's perfectly healthy pulmonary valve.
Yes, we are.
Doesn't the trauma of creating a second surgical site completely outweigh the benefits? It sounds like you're just creating a new problem on the right side of the heart.
You would definitely think so, but the rationale is rooted entirely in hemodynamics and longevity.
Okay, how so?
Well, the high-pressure left side of the heart rapidly degrades artificial tissue valves, especially in younger patients.
Right.
But if you take the patient's native living pulmonary trunk and use it to replace the aortic root, that living tissue adapts to the intense left-sided pressures beautifully. It can even grow with the patient.
Wow. And to fix the hole you just made on the right side.
You implant a pulmonary homograft, which is a valve from a human donor.
Oh, I see.
Because the right side of the heart is a vastly lower pressure system, that homograft survives much longer there than it ever would on the left.
That makes a lot of sense.
The patient gets a durable, living aortic valve and entirely avoids the lifelong anticoagulation required by mechanical valves.
That is a brilliant anatomical trade. Okay, moving to the coronaries. The text outlines the progression of coronary artery disease,
Starting from a simple fatty streak of lipid-laden macrophages.
and eventually developing into a fibrolipid plaque.
And the structure of that plaque is critical. You have an inflammatory necrotic core encased by a fibrous cap. As that plaque grows, it narrows the arterial lumen, restricting blood flow.
And when that narrowing becomes critical, the AHA outlines strict Class I indications for coronary artery bypass grafting,
Right.
or CABG.
Right.
You operate if there is significant left main stenosis of greater than 50%, or severe three-vessel disease, particularly if the patient has an ejection fraction of less than 50%.
But, decisive to operate isn't just about looking at a blocked vessel on an angiogram. It's really about quantifying the patient's overall ability to survive the physiological trauma of the operation itself.
Which is why the sources emphasize the additive Euro score for risk stratification.
Exactly. It calculates mortality risk by adding up specific patient, cardiac, and operative factors.
But it's not just a random point system, is it?
No, not at all. The points reflect the physiological reality. For instance, active endocarditis adds 3 points.
Because you aren't just dealing with mechanics.
Right. You're operating in a highly infected, inflamed field where the tissues are friable and the risk of post-op sepsis is massive.
Makes sense.
A recent myocardial infarction within 90 days adds 2 points because the tissue is still fragile and recovering from injury.
And poor left ventricular function.
With an ejection fraction under 30%, that adds another 3 points because the pump barely has the reserve to sustain normal life, let alone the massive inflammatory hit of cardiopulmonary bypass.
Which perfectly bridges us to the critical aftermath, Because surviving the operating table is really only half the battle.
It truly is.
Once that aorta is unclamped and the chest is wired shut, the patient's body has to actually tolerate the repairs. The ICU is where the physiological bill comes due.
And standard monitoring is incredibly rigorous. Continuous ECG, central venous pressure, and tracking both core and peripheral temperatures.
And managing mediastinal bleeding is arguably the most immediate ICU challenge, right?
Absolutely. You have chest tubes draining the surgical site. If those tubes are dumping blood, you have to make a rapid differential diagnosis.
Right. Is this a surgical bleed where a suture line is leaking?
Huh.
Or is the patient experiencing a systemic coagulopathy?
Exactly. And the sources rely heavily on a thromboelastogram, or TEG, to make that call.
So how does that differ from just ordering a standard coagulation panel from the lab?
Well, a standard lab test gives you static numbers that, take an hour to result. A TEG gives you a dynamic graphical representation of the entire clot life cycle in real time.
Real time is crucial there.
Oh, completely. It measures exactly how fast the initial fibrin strands form, the ultimate maximum amplitude or strength of the clot, and whether the clot is breaking down too quickly through fibrinolysis.
So if the patient is bleeding heavily, but the TEG shows totally normal, strong coagulation,
Then you have a mechanical surgical leak. The patient needs an immediate resternotomy to find the open vessel.
but if the TEG shows a weak, slow-forming clot,
Then you have a coagulopathy, and you target your treatment with specific blood products like cryoprecipitate or platelets.
fascinating. Another major postoperative hurdle is low cardiac output syndrome, where the recovering heart simply isn't pumping enough volume to sustain the organs.
Right, and the text discusses optimizing preload with fluids, contractility with inotropes, and reducing afterload.
But when pharmacology fails, the next step is mechanical, the intra-aortic balloon pump, or IABP.
The IABP is just a fascinating piece of hardware. It's a balloon catheter positioned in the descending aorta.
And how does it work, timing-wise?
It inflates during diastole, which displaces blood backward into the aortic root, directly augmenting oxygen supply to the coronary arteries.
Okay.
Then it rapidly deflates just milliseconds before systole. This sudden deflation creates a vacuum effect in the aorta,
Which reduces the afterload.
drastically, making it much easier for a stunned, weak left ventricle to pump blood forward.
But it has absolute contraindications. You cannot use it if the patient has aortic regurgitation.
Definitely not. If the aortic valve is incompetent, inflating that balloon in the aorta would just blast blood backward into the already failing left ventricle.
Ouch. And you absolutely cannot use it if there's an aortic dissection, right?
Right, because the mechanical stress of the balloon could easily rupture the fragile aortic wall.
Yeah.
The hardware is only effective if the structural anatomy can handle it.
Right. Now let's talk about temperature, because this really ties everything together.
It does.
During bypass in the OR, we actively use hypothermia to lower the metabolic rate and protect the brain and organs from ischemia.
Yes, very standard.
But in the ICU, post-op hypothermia is listed as a major life-threatening danger, causing intense vasoconstriction, arrhythmias, and coagulopathy. So what does this all mean?
It's a paradox, isn't it?
Yeah. If hypothermia is our best tool during bypass, why is it suddenly our worst enemy in the ICU?
This raises an important question, and the answer lies entirely in the transition of physiological states.
Okay.
On bypass, the patient is fully anesthetized, paralyzed, and their circulation is mechanically supported by the pump.
So it's a state of controlled artificial metabolic suppression.
Exactly. But in the ICU, as the anesthesia wears off, hypothermia triggers a massive, unsuppressed physiological stress response. The body attempts to warm itself by violently shivering.
And shivering increases the metabolic oxygen demand of the skeletal muscles by up to 300%.
Exactly. The oxygen demand skyrockets. At the exact same time, the cold temperature causes intense systemic vasoconstriction.
Forcing a recovering weak heart to pump against massive peripheral resistance.
Yes. And if we connect this all the way back to the very first concept we discussed today, the Bohr effect.
Oh. Hypothermia causes a leftward shift of the oxygen dissociation curve.
The loop closes perfectly. The left shift means the hemoglobin holds onto the oxygen with a much higher affinity.
So right at the exact moment when the violently shivering muscles and the recovering vital organs are screaming for oxygen, the cold blood refuses to release it.
Exactly. And the extreme vasoconstriction means less blood is even reaching the tissues in the first place. It is a perfect storm for profound tissue hypoxia, lactic acidosis, and cardiovascular collapse.
Wow. It is incredible how perfectly all these principles connect. The basic physiology you learn on day one of medical school is the exact same physiology dictating life and death decisions in the ICU.
It really is. And, as we look at how far these techniques have come, I want to leave the listener pondering the future of this field.
What are you thinking?
Well, as endovascular stent grafts and transcatheter valves where we can replace valves or repair aortas through a simple puncture in the groin become increasingly advanced,
Yeah.
will the traditional open chest cardiopulmonary bypass eventually become a thing of the past? Or will the gold standard durability and direct anatomical visualization of open surgery always hold its place? It is really the defining debate of modern cardiovascular medicine.
It is definitely an evolving frontier. And as promised for our medical learners out there, before we go, here's a quick clinical exercise for you to mull over.
Let's hear it.
You are managing a patient 2 hours post-CABG. Their core temperature is profoundly low, they are shivering violently, and their arterial blood gas shows a developing metabolic acidosis.
A classic scenario.
Right. Based on the physiology we discussed today regarding the oxygen dissociation curve and metabolic demand, what are the immediate physiological consequences of this shivering, and what should be your first step in management?
Engaging actively with these exact clinical scenarios is the key to mastering cardiac care. The textbook is really just the beginning. The real test is applying it safely at the bedside.
Absolutely. So next time you think of the heart as just a mechanical pump, remember the invisible forces, the hydrostatic pressures, the shifting oxygen affinities, the cellular stress pathways that keep the engine running. Keep studying, keep questioning, and we'll see you next time.